For those of you who might be new to the center, basically our focus is on racial and ethnic health disparities research, and our primary mission is to really produce the next generation of scholars who will really take the challenge of utilizing social science research to improve health disparities. So we have a number of our graduate fellows in attendance today. Chat them up. Raise your hands if you don't mind so they know who you are. Don't hide. Don't be shy. Right? So if you're interested in learning more about the center, they are the best folks to ask. Right? We also have partners from our nursing collaborative, from the College of Nursing that are here with us. I think a few of you, this is your first day on the job, so welcome. Yeah, hopefully it's been a good first day, and we love having you here and in attendance with us. This particular segment of our overall center is extremely important because we're able to bring in national/international leaders in health disparities research here at the University of New Mexico, which is amazing for our students, for our faculty, and everybody else within the UNM community to be able to have access to some of the best and brightest and most profound research really going on in the world in this research area. Today in particular is the ideal talk for the focus of our center. We have Dr. Hortensia Amaro, who's coming from the University of Southern California. I had a pleasure of speaking with you in detail last night. This is actually a coming home for you. She grew up in Los Angeles, so it's an honor, I think, that they have you back and you're able to participate in the community that you grew up in. She will currently serve as the Dean's Professor of Social Work and Preventive Medicine, as well as an Associate Provost. So it gives you some sense of her ability to balance both administrative duties at the highest levels as well as applied research. You know, looking at her research record, it's enough to be intimidated. Well over 130 research articles, as well as some of the leading publications that have really changed the game in her research areas, which include mental health generally, substance abuse, HIV/AIDS prevention. So it really is just a top-notch, you know, in terms of pedigree, the best you can be in terms of an academic. But what I'm most excited about, and why I think this really showcases what our particular center is all about, is beyond just publishing academic research, she's been able to put that into practice in an applied way, really utilizing her skill set to improve the lives of the communities in which she's been involved with. Right? She's also done a ton of policy work at the highest level. So it really encompasses really what we want of our fellows, somebody that's not only an academic researcher but is able to put that into practice. So I could go on for days literally about the fine work that she's been able to do, but I want to give her plenty of time. So please give her a warm UNM welcome.
Thank you. It's really a pleasure to be here. I want to thank you for those of you who helped to organize this, for really being patient. We've been trying to set for how long now? A couple of years. So, the issue of schedule and then my transition from Northeastern University to the University of Southern California and all that, but I'm really happy to be here. I'm familiar from about the work you do here a bit from my colleague and dear friend Lisa Kakari Stone, who I've known for quite a while. So I really look forward to this two-day visit with you. My angle is really going to be more on how I got to the point of doing this work, with the hope of perhaps encouraging you to really think about, reflect a bit about how you got to the work that you're doing and why it is important to do that. So I have, my experience has been that my research has been largely shaped by who I am in this society, but what my life experiences have been. And so that's why I want to focus a bit on that, because often in an academic setting, we don't really talk about that. And yet I have found that it is a very powerful source of inspiration, of insight, of giving voice to issues that maybe aren't really visible in the literature, and to really addressing and informing important scientific questions. And of course, I think that this is very relevant to the mission of this center. Because in the end, what science is about, in my opinion, is scientific discovery, but for what? For improving life conditions, for improving or developing approaches and technologies that improve life conditions of individuals, that address issues of health and disease, etc. So it's really this translational part that in the end is the end purpose of science. And I would think that this translational dimension is kind of like, or should be part of the genetic code of a policy research center, right? Because policy is about translation of research to guidelines for and policy initiatives that could address health issues. So that's just a slight change in the angle of my talk. I will still cover our Boston Consortium model. Let's see if I can figure out how to do this. Oh, there we go. So, this slide shows with kind of a typical perspective on translational research, for example, in substance abuse treatment, but it could be on a number of other health conditions where, you start off with sort of more the biological perspective, and maybe even at the molecular level or the genetic level, and, you move to maybe imaging studies of the brain, and then you move to some kind of medication application, and then eventually to some kind of clinical intervention or service-related study. Notice that here is really not even like the public health dimension, which would be another kind of equivalent to this, but on a larger scale. But, and this is, I think, how most of the funded research goes, sort of tends to go in this direction, and people seem to think that, in general, this is the right progression. But an alternative and less often used approach is one that starts with interventions from real life experience through practice, insights from practice, nursing practice, public health practice, practice in the mental health community, indigenous or, community, culturally kind of embedded healing practices, and then engaging in a reflective process about those, using data and theory to formalize those, and in a way, going kind of back in the other direction, and then thinking back about, well, what may be some biological aspects that are involved here. So mainly, I just want to highlight that the other direction is a valuable one, too. In fact, I think it's probably the one that I prefer myself and that I've used in some of my research, if not in most of it. Oops. So regardless of the starting point, the scientist uses, going in one direction or the other, the ultimate goal really of the scientific inquiry, as I mentioned, is really to inform and improve practice and eventually to improve health conditions and address risks. I think through the course of my mentoring that I received and my involvement with community agencies, both of those really helped me to understand the personal life experience and personal observation about communities that I lived in and that I worked with were valid and valuable starting points of research. So I just want to, emphasize and encourage you to think about that and not undervalue that. There's a richness there. So one approach to scientific inquiry that starts with practice is action research or participatory action research. I know, some of you may be involved in those methods. which is a reflective process of progressive problem solving led by individuals working with others in teams as part of a community of practice, if you would, to improve the way that they address issues or solve problems. So quality improvement processes, for example, used in the private sector can be thought of as one of these, a scientific form of action research. So the application of QI methods in the private sector are actually increasingly being used to improve substance abuse treatment delivery. And an example of this is the Network for Improvement of Addiction Treatment, NIATEX. Have any people heard of it? Some people have. So this is an initiative that trains community-based service organizations and their staff in a method and for quality improvement that are similar to action research in some ways, but applied to those contexts. So in the clinical programs that I developed in Boston, we consistently use this change cycle within that NIATEX framework and methodology to do things like decrease significantly the wait time from the moment somebody contacts us about wanting to enter treatment to the time that they're admitted. Things like increased retention within the first month of residential treatment, which is a critical period, because if you can make it past that, your chances increase significantly for making it through longer stages of treatment. So using that process, this change cycle where there's a community of practice that comes together that included counselors, administrators, clients in the program, we identified what were the issues related to increasing access, where were we getting blocks, and retention. And then we identified interventions we could do. We measured data points before, during, and after in a brief period of time. You don't have to wait 5 years to do this. You can do it in a 3-month period. And so it's a way to change systems. You can also do a larger study where you take longer, but it's a way, it's another approach of using practice as the lead to research. So our wait time for residential treatment, for example, went from 3 weeks to 24 hours. Our treatment retention of pregnant women in residential treatment, was something like 15% in the first month, and we got it up to 85% in the first month. So if one strategy you use doesn't work, you change it, and you try a different one, and you only keep those that work. It's an example of sort of how to go about it the other way. Whoa, keep going the wrong way. I've mentioned already that I really believe that personal history and lived experience are highly relevant and rich sources of ideas for formulation of theory, of research questions, even methodology. I don't know now in your training, but when I was being trained, certainly objectivity is one of the principles of the scientific method. And, there's an assumption that personal experience and personal perspective really does not allow you to be objective, and that it's really a detriment in research rather than an asset. Well, we know from the phenomenology of science that, science isn't objective, that scientists are not objective, that we're not exempt from the socialization of our society and the values and internalization of values and perspectives and biases that each society has. We're human. We're not exempt from that. So who we are, how we see the world and its problems and solutions, and are embedded in our life and experience in society. So I realize this is somewhat of a departure, although I think maybe things are starting to turn around in this area. So I do believe that for everyone, an understanding of the larger forces that has shaped your own life and formation as a researcher is a great asset. To have that understanding, to know where that came from for you, and helps you to recognize the types of lenses that you're using to understand the world around you and the research questions you ask or you don't ask, and how you interpret findings. It was interesting because I was having breakfast with some of the students, and we had a very stimulating discussion. At the end, I said, okay, now I want to go around, I want to ask you, what is your inspiration and what is your aspiration? And so they answered those questions, really impressively well. And then we noted that everybody had as their inspiration they were all grounded, their inspirations were grounded on their lived experience and their observations, especially about issues of social justice, about inequities, and then their aspirations were really about trying to bring forth a different understanding in science and a set of solutions that would help to address those. And then I asked them if they thought this was the case for all of their peers. And then we started noticing in the discussion that there seemed to be, at least for that small sample of 4 or 5 of us at breakfast, a sense that, maybe not all students share this perspective. And that some will say to you, well, I'm going into it because I love science and I like to ask questions and I like to answer them. I like to be able to train rats to go in a maze and do this or that. Or, that's an interesting observation. And I wonder whether, as part of our training, we should ask students to reflect more on what's been their inspiration and what are their aspirations in terms of contribution to science. And in that way, perhaps produce research that maybe is really more responsive to social policy needs, and to current public health problems. I'd love to hear what you think about that during the discussion. So I'm going to tell you a little bit very little about what my trajectory was, because obviously, I'm old and there's a lot of history now. So, my family, I was born in Cuba. We came here when I was 9 years old. We came as refugees. I lived in a working class family in Cuba. My mother was a kindergarten teacher in the public schools. And we came, and I grew up in public housing in LA when my family came here, because of course we didn't speak English. My parents, were working in factories, whatever job they could get, and but early on, even as a young girl growing up in Cuba, I understood very early that gender matters in one's life, trajectory and in the opportunities. And, I'm happy to tell you stories about how I came to understand that. But in Cuba, I was constantly told, oh, you can't do that. Well, why? Because you're a girl. I mean, it was like an everyday thing I heard. So, I got the message, And so gender, the role of gender really, I think, was something that I became aware of, that shaped me and my interest. And then as a minority and immigrant in this country, I became acutely aware of how social inequities and social status related to ethnicity and to color and to class really were significant factors that shape your life opportunities, and not only of mine, but of the kids I grew up with in public housing and other kids. But it took a while actually for me to really formalize this understanding. It wasn't until I went to university that I was able to read more about these issues and say, oh, that's what was going on when that teacher did that, or, that's what I kept seeing over and over again when I was growing up. So, of course, when I was going to UCLA, none of this could even be discussed except with the other minority students, because if you ever brought up this in class, you would be accused of being too narrow in your focus. But nobody who looked like me or who had my kind of experience, I didn't used to always have white hair, so I did look more Latina, okay? But, I saw nothing in social psychology or in developmental psychology that had anything to do with the life experience I had or the kids that I grew up with had. So I always had to have a separate reading list to kind of keep myself sane. So that's when I read Pablo Freire and Malcolm X and other people like that they weren't about to have on the syllabus. But it did help me to understand sort of my place in this society as perceived by others, and to at least know what it was that I was dealing with, and to give me a perspective on understanding if I wanted to contribute to improvement of conditions in certain communities. I had to really be aware of, well, what was the social construction of that? So knowing something and being able to articulate and understanding that. So obviously, who would have thought that Nina, which was the nickname in my family, that little girl right there, and then, the refugee right here, was going to ever be Dr. Amaro. I mean, no teacher ever predicted that. In fact, in the 4th grade, I was given an IQ test in Spanish, and then it was used for the 7th grade to place me in a class for, kids, special needs kids. And in high school, my advisor told me I should become a secretary. So, I don't know what predictive model would have worked in this situation, but obviously something was going on that helped, and I'm happy to talk about what I think that was, because there were people particularly who really believed, some teachers who did believe in me and encouraged me in that, and mentors that I've had, that was essential. And then, of course, my desire to rebel and not just abide by what was expected of me. So important to me became, this immigrant background, very, very shaping, informing aspect of my life, recognizing the intersect with gender. And then grounding in the community is something that then became very important to me. And you'll see, that's why I ended up doing the work I did. This just happens to be an example of one of the things I did while I was an undergraduate at UCLA. 3 undergraduates, Latino undergraduates, and I started a bilingual bicultural preschool when we were seniors actually juniors, for 150 kids in the LA, in the Pico Union area in LA. And that really helped me to stay connected to the issues that were important to me. So this is when I grew up. These are some of the, missing from here, I think it's hidden beside that is Martin Luther King. But so I also recognize, okay, and this is something for you to think about, that the historical periods that you grew up in really shape you. And so you need to ask yourself, those who are younger, what is this historical period, especially, for example, in terms of technology and what that means for society, et cetera, and what are the messages and the values that are inherent, those that are shaping your work. So clearly for me, the Chicano movement, the civil rights movement, the women's movement, et cetera, the peace movement, these were things that really were very prominent in the picture at the time. Kent State and the students being shot, and bras being burned, and all of that, and deciding whether do I stay in my cubicle or study, or do I go demonstrate, and is it revolution or is it science and knowledge that's going to bring about change? And those were the issues that I was asking myself, and the decisions we're having to make. So obviously, huge kind of generational set of factors that impact who you are and what you end up doing, and what questions you ask and what questions you don't ask. Then there was inspiration from a particular event that happened that really led to my dissertation topic. So in 1977, Congress passed the Hyde Amendment. So some of you who are aware of reproductive rights issues know that this was the first time that poor women were not able to get funding for abortions under Medicaid. And so the first woman to die after this from an illegal abortion was Rosario Jimenez, a Chicana from McAllen, Texas. And the CDC, so she became a big case. The women's movement said, see what happens and when you withdraw support. And anyway, there was a book that was written by Ellen Frankfurt, who was a CDC physician, who really wrote a book about why she really died. And the CDC had attributed her death to cultural factors. And Ellen Frankfurt revealed that, in fact, she had had 2 previous legal abortions. And so she had not gone to a partera because that was her cultural preference, but because she lacked access to services. So I decided to do my dissertation on Mexican American women's reproductive beliefs and experiences, not just abortion, but more generally, and to look at the role of gender, culture, and religion. And, I think I was the only graduate student at the time at UCLA who was doing work in East LA instead of with rats in the basement or with undergraduates in psychology classes. So, but it was a great experience. I learned a lot from that, and I was able to publish that paper. Then AIDS came, and AIDS changed everything. Changed everything in my professional life and in my personal life. When I was conducting, at this time, I was a new faculty member at Boston University in the School of Medicine and Pediatrics, and I was conducting a study with colleagues there, senior colleagues, and I was not PI of that study. It was a NIDA study, but I was director of the study. And we were interviewing women. It was a study of women's drug use during pregnancy, and we were interviewing women at various points in pregnancy and postpartum and looking at birth outcomes, and we were interested in the degree to which substance use impacted various pregnancy-related outcomes and infant-related outcomes. And so I oversaw the field staff, but periodically I would do interviews because I really wanted to kind of be in touch with the lives and the information women were giving us. And I never forget the day I interviewed in the postpartum ward a woman I'll name Mary, who was an African-American woman. She was probably 27 years old. She was addicted to heroin and had been in the sex industry to pay for her habit. And so she had HIV infection, and she was waiting to hear whether her baby was infected. And I sat there and I spoke with her, and I heard her story and sensed, like her desperation, and saw at the time, AIDS, there was a lot of stigma. She was unaware of services, really wasn't getting the help she needed. And I just, something about meeting Mary and her story really was disturbing to me. And I thought, how can I focus? My career was going great. I was getting grants. I was publishing papers in good journals. But how could I focus on publishing findings that may never be read by anybody, or maybe in 10 years somebody will say, oh, maybe this was useful. When in papers that maybe would do little to address the issues of women like Mary. Then tragedy knocked on my door. A few months after that, I interviewed Mary, my 27-year-old brother, who I had basically raised, since he was a year old and we came here, was diagnosed with AIDS. And this was, as you can imagine, devastating for me and for my family. This was the beginning of the AIDS epidemic. There were no treatments. You probably remember the pictures of what people looked like then and what life quality was. So it really changed everything. We then, it wasn't just my brother, we constantly were going to vigils and we were going to funerals because people in the gay community were dying. People in the Latino community, some of the leaders in the Latino community in Boston, residents. So we were going to constantly. It just seemed at that time, if you lived through that period and you were at all proximal to that, you remember the impact. But so I became very involved in doing that and in working with the Latino community to set up two CBOs, the Multicultural AIDS Coalition and the Latin American Health Institute, which still exist in Boston. And it was also during this time that I set up my first substance abuse treatment intervention in Boston. I had two mentors, Ken Edlin and Katie Portis, who really were people who facilitated this work for me. Ken was the head of OBGYN at BU and really helped me to get this grant. Katie Porter had been an injection drug user, sex worker, and was an advocate now in the Boston community. And they both reached out to me and said, "You have to do something. You're an academic. You have to do something." And they really encouraged me to get into this field. And that's really how my work on HIV prevention began. That's how my work on substance abuse began. And those were really the roots of the studies that ended up starting to inform the Boston Consortium model. So through those years, we obtained data on our clinical populations in the programs that I started, several residential programs, several outpatient programs, mostly for women, some now for men, and documenting the issue of co-occurring disorders. And in our observation that treatment just, wasn't prepared. Substance abuse field wasn't at that time prepared to really respond to that. So we developed a lot of community partnerships. We developed treatment programs, which is really where we ended up doing a lot of the research in addition to other sites outside of the programs that I developed. We brought a lot of these issues to the legislature and every year established a one-year, an annual event at the State House where women in recovery and their children could talk to legislators to basically tell them about the services that they needed and the importance of issues of trauma. The programs also became very well known nationally and were visited by people like Richard Carmona, the ex-Surgeon General, and the drug czar, etc. So we were able to, in this service platform that we developed, we were able to then conduct a series, develop interventions, test interventions, and document their efficacy. And one of those is the Boston Consortium model that you read about. So I wanted to now tell you a little bit more, just really briefly, about what the model was and what it is that we found. So, we had been observing clinically that the population we were serving, and at that time it was mostly women, but later we observed pretty much the same with men, that yes, substance abuse was an issue, but you couldn't just provide substance abuse treatment because issues of co-occurring mental illness and horrific histories of trauma, in addition to poverty, lack of employment and education skills, were really like a big wad of issues that women were dealing with. And so if you were just going to single out substance abuse treatment, you probably weren't going to have much success. And, we felt the frustration of trying that approach because what do you do about the housing? What do you do about the job? What do you do about childcare? All of it. And so we developed a model specifically to address and to integrate issues of trauma, addiction, and mental illness. So we tested, this was a study that was part of a larger 9-site study that's called the SAMHSA Women's Co-occurring Disorders and Violence Study. In our site in Boston, we had methadone outpatient and residential treatment modalities participating. Basically, the idea was that if we combine substance abuse treatment, mental health trauma treatment, we would, and delivered an integrated treatment model, that we would get better outcomes. That was the research question. So components were obviously psychotherapy, pharmacology, recovery skills building. Recovery skills building dealing with the myriad of things that I mentioned. How do you work on with the family reunification system, with child welfare, because this was a huge issue. Women would leave treatment because of it, or they would relapse because of the stress when their kids were taken away. Recovery skills in all the areas that I mentioned. At the systems level, so, this looks easy, it looks like a little diagram, but this took a lot of work, because that meant that we had to totally retrain the staff in all the intervention sites on how do you deliver integrated treatment of trauma. Not easy when, people have been trained in one way. So that was very intensive training, continued supervision, continued training. We still continue to provide training and updates on that. So I don't want to underemphasize what it took to implement the model, because training and basically changing the system is not just, well, here's a trauma group. It's really looking at how you deliver services and making sure that issues of power, that you don't have an environment where women are going to feel re-victimized. Okay, so basically that was it. And the mental health and trauma was really done in collaboration with the Department of Psychiatry, as well as a number of community agency providers that were our partners. So the results, led to being accepted into the NREP, the Sampsons National Registry of Evidence-Based Programs and Practices. They have a scientific panel and review process, and so that was significant to be able to accomplish that, because that means that other people could use that model as an evidence-based approach. You've read the analysis, but basically we found that women in the intervention condition compared to those in services as usual were more likely to be abstinents at 6 and 12-month follow-up. They were also more likely to have more significant reductions in mental health symptomatology and trauma symptomatology. And we measured HIV risk behavior, so not all the other sites did, but we also found that women in the intervention group were more likely to, were less likely to have HIV risk behaviors. In other words, more likely to use condoms, less likely to have multiple partners, less likely to have sex with risky partners. So and they were also more likely to increase in their relationship power measure that we used. So, and those with higher relationship power, that was related to HIV risk behavior. So I think that, what this told us, since so many women in our society have some kind of experience of trauma, but certainly it's very high among women in substance abuse treatment and in the mental health system, that if you're going to do HIV prevention, you really need to, you can't just do the HIV 101, you really need to address the underlying issues of trauma, because that really shapes how issues of boundaries, of self-care, of the partners they choose, of how they behave in relationships, etc. I know you can't see this, but hopefully if you get the copy of the presentation, you'll be able to see it. I want to say that it was very important for us that in this process, we also developed and produced and disseminated, all these were manualized treatments that we either developed or that were based on the best science available, or they were adaptations of existing evidence-based approaches. So I'll just give you one. At the very top is on spirituality and recovery. this really was not, yes. Okay, thank you. This is Women's Leadership Training Institute. So why would we have leadership? Leadership was really the way to kind of frame it, but this was really about regaining your voice and sense of agency, which for women in this population, especially with a history of trauma, is jeopardized. We have, these are some that were developed as part of the model, and other ones that have been developed since. This was on family reunification, pathways to family reunification. So why did we include this? This was part of our consortium model because losing custody or the threat that you will lose custody of your children is a major issue for poor women in substance abuse treatment or who are abusing substances. And it's very traumatic. And it will trigger trauma. It will trigger substance abuse in some cases. It can also be a motivation, to engage in treatment, but it can work both ways. So not knowing that system, demystifying the system and guiding women through what to do, as well as how to handle emotionally, the various possible outcomes, was really important. Economic success in recovery over here to address like basic skills. So, getting a checking account, how do you do a budget? How do you shop for food to get the best? Really simple things, but that women had never learned. And Saber es Poder was our cultural adaptation of trauma recovery and empowerment. Maxine Harris's model for trauma, group model for trauma intervention. I don't know if you're familiar with it. So we did a cultural adaptation. I'm happy to talk more later about what is the process we follow when we do cultural adaptations. This one over here is mindfulness, a moment by moment in women's recovery, a mindfulness-based approach to relapse prevention. This was an adaptation to the population, for this population, of John Kabat-Zinn's mindfulness-based stress reduction model, which you probably know. There's lots of research now documenting it and being implemented in many places. Well, I had been through the training. I was a yoga teacher at the time. I was practicing myself. And I thought, this was, before now it's everywhere, yoga and mindfulness. But at the time, it wasn't. And I thought, well, I think there are things here that women in our population could benefit from because of their trauma history. So grounding, strategies and skills in grounding, in quieting the mind, in being able to discern what are your thoughts, your emotions, and your bodily sensations that are related to stress that may be putting you at risk for relapse. Okay, so this intervention, MBSR, had a lot of skills that were really pertinent to that. But I knew it wasn't going to work with our population. But we did it anyway, the way, it was developed for a more high income, highly educated population. And so, it didn't work. I knew it was going to work. But we have a method to our madness, and, we collect data when we're implementing these about what's working and not working. And then we say, okay, didn't work. Here's what didn't work. We have our notes. We have what clients tell us. I said, we have to reframe this totally to relapse prevention, because women were saying, what does this have to do with me? There was all this high language in there. Literacy, we brought the literacy level down. We reframed, we kept all the, what I would call active ingredients in terms of the skills buildings, but we reframed them to be contextualized to their life experience, the things they were dealing with, not you don't get accepted to college and, or, you can't meet your mortgage payment. So we totally reframed it, and then we started delivering it, and every cycle we would improve it, and then women loved it, and they got it. They said, oh, yeah, stress, relapse. This is going to teach me how to reduce my stress, and they started using some of the techniques of using the breath, of, the stoplight technique, the body scan technique. This doesn't mean, we had no expectations that women were going to meditate for an hour or half an hour every day. That wasn't the point. It was learning certain skills of how do you quiet the mind, how do you tell the difference between what are your thoughts, your emotions, and your bodily sensations, that could give you a cue before you slap that judge, you know, that maybe you need to take a breath and to use a stoplight technique, you know. So it actually, I think, you know, can be very, very useful. So that's a little bit about sort of the products that we develop. We also develop this manual here called Integrated Substance Abuse, Mental Health and Trauma Treatment with Women, a case study, I think it's called source book or workbook on staff training. So because we'd done all this staff training, we thought we can't lose that. We had an interdisciplinary, one of our formats for this work clinically was an interdisciplinary clinical team that met periodically and discussed, you know, cases, and everybody from their perspective. But so what this presents is it presents cases, you know, that are largely factual, sometimes emphasizing certain things for the purpose of teaching or bringing out a specific clinical issue, and then there's a perspective of, okay, if you only looked at this case from a substance abuse perspective, what's your analysis? If you only looked at it from a mental health perspective, what's your analysis? And if you looked at it in an integrated way, what is it that you would say are the next steps? So, you know, it's being used in some schools of social work to train clinicians. It might be useful for some staff at treatment agencies, etc. So, so you know, we have done a lot on intervention, adaptation, development, which I'm happy to talk to you about. We did publish a couple of papers on spiritual self-schema therapy, which was developed at Yale by Mark Golan. That's an individualized treatment approach. It's a different, usually, it's a mindfulness-based technique also that's used. The mindfulness-based relapse prevention, we did write a paper on how we did the adaptation, and now we're writing up some of the findings. We did another version of our leadership training in HIV risk prevention that was funded by the National AIDS Fund, and we have that was a small pilot. We have some preliminary data from that. We developed a curriculum on addiction in the brain. Whoops, sorry. That was not, going the wrong way. The addiction in the brain, we haven't done any research on. That was just like we saw a need, and we said, you know, we have these people in treatment who have no idea how the chemicals they've consumed have impacted their brain chemistry, and how that explains some of their affective states and some of their physical conditions, like not being able to sleep, etc. And so a couple of my undergraduate neuropsych students, along with some of our staff and clinicians with feedback from clients, developed a curriculum. I think this one's like 6 sessions that can be delivered, you know, in a low literacy way to people in treatment to help them understand. And we started that with, you know, the goal of doing it, but the first step was have focus groups with the staff and the women in the program, and ask them, what do they want to know about the effects of addiction in the brain? What are the questions that come up in their mind? What do they worry about? And then that's how we approached, you know, how to present the science to them. And then, of course, we more recently we just finished a study or a project on reentry, women reentering from incarceration, and integrated into the substance abuse treatment was a collaboration with a business school at Northeastern University, and we for this developed entrepreneurship training program for those women as well. So that's a little bit of some of the other treatment innovations and interventions that we've developed in those programs. So, you know, I would encourage you to go the path less traveled as such, you know, or to at least not be afraid to follow the things that really are your passion and that motivate you. Yes, we have to be practical in some ways, And so that's important to balance it too. But really try to ground yourself and center yourself in why is it that you want, that motivated you to study? What is it that motivated you to want to be a health researcher? And, have courage to inform your thinking through your personal history. You need to formalize that thinking. You can't stay at the, well, this happened to me level, but, use that experience to inform how you look at theory and how you look at data and at the questions that you can ask. This is my contact information in case you want to be in touch. And I thank you very much. Thank you for your attention.
So if you're not familiar with our format, before we open it up to a full Q&A, we have two, I think we call you guys initial brief discussants, right, which are somewhat of following a conference format where folks that have read a bit of the speaker's work will kind of lead us into the Q&A. So we have Dr. Magdalena Avila from the College of Education that's here to lead that on the faculty front, and Yahaira Pena Esparza, who's a soon-to-be doctor, a psychology PhD student working on her dissertation. So soon-to-be. So I don't know who wants to go first, but they will do their part of the process, and then we'll open it up to a full Q&A. Sure. Yeah, I think for the camera's sake, you have to be camera ready.
Camera at its weight, right here. Dr. Hortensia Amaro, thank you so much for coming here and being very honest and sharing what your inspiration has been for this research and really motivating us to continue doing what we're doing. My question is related to the work that you've done with the Boston Consortium, and what I'd like to ask you to do is to reflect on the barriers to the integration and the cultural adaptation of mental health treatment and how we can continue to address these barriers successfully, what the next steps are. Yeah.
Oh, do you want me to answer now? Okay, sure. Okay. Sure. Good questions. Very good questions. Let me tell you, this whole project on integration was huge and massive and very, very challenging. To start off, we had, I think it was like 4 years to carry out the study and 2 years before to basically set up, what we were going to do and build the community partnerships and develop the interventions. It was not easy. So our first meetings, we brought together all these sectors, right, from people from mental health, addiction, domestic violence, etc. And we really wanted to engage in a discussion about, okay, we're basically serving the same population, but they're in a very segmented way and explaining the whole idea of integrated treatment. Well, I wasn't more than 15 minutes into the first, kind of introduction when I got stopped because, I was using the term, I think it was clients, right? And people, some people in other sectors objected to it. So, survivors, women in the domestic violence sphere was, we're survivors, we're not clients, or, our people we work with are survivors. And then people in mental health they're patients, So can you imagine? We had that discussion easily for 6 months, okay? But what it was underlying, they were philosophical and disciplinary differences. Talk about not being able to talk across disciplines, right? I know you're working on this. So that was a lot of work that had to be done to say, and let me tell you, so you probably wonder, what did you come up with, right? Consumers / recovering / survivors, because we couldn't come up with anything new. It was the most awkward term, but I said, this is like the history of discussing Hispanic, Latino. I'm not spending another breath on that. Let's move on and do something, So, but, that was just emblematic of sort of the root issues of, perspectives, disciplinary training. But, at least we got people engaged, and then we were able to go on and discuss other issues, But obviously, people in substance abuse treatment felt like addiction is the problem. We'll deal with the mental health problem later. Don't even bring up trauma, they'll leave, because they've been self-medicating. The mental health people were going, substance abuse is just a manifestation of underlying mental illness. Deal with that later. So it was like totally different priorities. And we said, we think we need to deal with it all at the same time. And everybody's like, how do you deal with it all at the same time? At that time, that was like overwhelming. And so as we started doing training and more capacity building within the agencies we were working with and with the staff, and bringing in, national experts who would lay it all out, the relationship between trauma, addiction, and mental illness, and consequences, people began to feel more comfortable. As they got trained in exactly what to do clinically, and they became competent, certified in different treatment approaches, they became more willing to really, and more confident, able to deliver these interventions. So those are a lot of barriers. Of course, the continuing barriers which were present then are really policy barriers related to funding streams. And so, you have different funding streams saying you need to deal with this and not that, and so that continues to be a barrier. I think there's a little bit, more leeway that developed. For example, a substance abuse treatment that we delivered, we were able to reimburse if we were delivering trauma, because they finally got it, that was, one of the underlying conditions. But I think that the integration really needs to be at all the levels, and the funding streams and the sources of payment is really the beginning, because from there, everything else gets shaped. So you guys are in a great place to do something about that. The issues related to adaptation, cultural adaptation, I think the biggest challenge in our context, because we weren't, we already had a staff that understood, and leadership that understood that this was important, but it's how long it takes to do it, and the kind of work that it takes to do. You don't sit over the weekend and say, okay, I'm going to culturally adapt this, and say personalismo here, and family relationships there, and shade in the colors of the characters. No, it's really, you got to go to the deeper level. And so a great article on this. I have a bibliography on this. In fact, I have a chapter that I published with one of our previous doctoral students, Fabiana Wallace, on how we adapted the TREM model, Trauma Recovery and Empowerment, which cites some of the literature, especially the contributions that Guillermo Bernal and people like Felipe Castro have published on sort of the frameworks that you can use for cultural adaptations, and what are the dimensions that you need to look at, so that you go deeper and not just do the surface changes. So, in our trauma intervention, it was many cycles of doing that, of discussions, of framing it. But some of the things we did was, obviously we're lower the literacy level, bring in issues that were not included in what issues of trauma were covered. So issues of immigration, of war-related crimes, of loss of one's country, of separation of family related to immigration and war, issues of discrimination and skin color, issues of gender and how that manifests, gender expectations that are maybe culturally embedded, issues of how Latina are seen in the media. And so, basically who Latinas are in this country that is related to their marginalization. Because we kept notes of things that women said during sessions, and when the TREM is it elicits a lot of responses from participants and examples, and so we ended up using some of those. We changed some things, like there was a piece on body image in TREM that really Latinas didn't relate to at all, and because it was about thinness, and it was focused in a way that really didn't relate. So instead we brought in the work of Frida Kahlo, because her work is really very much about trauma and body image and about pain, and how she portrayed her body. So we brought her work in as a tool to project, for women to project their own kind of trauma, and how that trauma became part of their body or manifests itself in the body, to deal with with that kind of internalization into the body of the traumatic experience. So there were things like that, that we did, obviously, and then we translated it, but it was really the cultural adaptation that was challenging. Does that answer your question? Yeah. Okay.
Muchísimas gracias por la presentación. I have a smaller question, but overall, kind of the macro level question. Overall, I think that your academic work and your presentation today in regards to science and practice and how you merged it really acknowledges what I call the science of our communities. Because usually we think of science as a very strong empirical science, whereas when we're talking about practices, and what you showed through your research today to me is the fact that those practices which can be sustained within the community are going to be the most powerful to sustain over time, and because they come from the locality, the customs, the cultural embeddedness of the community. So given the sense of your work, I would sort of ask you as well, I think that as academics, we live in a duality of worlds, especially as people of color academics, when we come either from a different class system, and how you have also met that challenge in walking that line of duality of worlds and sustaining the meritocracy of research in both capacity, at the community capacity as well as at the academic community capacity, which is very different. Because you said something that was really, really important at the very beginning, and that was accountability. The community contacted you and they said, we want you to do this, we want you to do it this way. And you felt your sense of obligación and that element of accountability. So how you've woven that in, which is not an easy thing to do, I think is a theme that has come across very strongly. And I think it's really important for the young scholars in the room as well as the practitioners. And that is that sometimes we focus so hard on theoretical interventions because they're the latest in this, the scholarship world, when yet the actual application is not going to work. So we have to move things in two levels of trajectory. So I want you to, if you could address that in terms of your work and how you basically walk that line. And then I had a small little question, which was how about traditional medicine, how that was integrated into your model? Because when you talked about Rosie and how that initiated this whole dissertation question for you, is she said she wanted to go to the clinic. She wanted a choice. And she made that very clear, rather than just, you think I could go to a partera, but she wanted a choice to be able to go to the clinic. And that's important, that we just not track our gente into a certain place. So.
Oh, such complex and thoughtful questions. So This issue of duality, I haven't resolved it. You know, I feel it every day. It's a real challenge. It takes a lot of energy, and really, unless you're experiencing it, you have no idea, right? What it means in every conversation, in every assumption somebody makes, and in how we internalized it, you know. And I've worked a lot on internalizing, and I still do. When I got my letter from the Institute of Medicine, you know, that I had been elected a member, I went, Hortensia Amaro, there's another one. They must have mistaken me with her. And I'm not the only Latina who's responded that way to those letters. I have a good colleague who just got inducted into the national, actually we went to UCLA together, and he's in education. He just got inducted to the National Academy of Education. And he told me, I mean, he talks like this, real barrio. He said, yeah, man, you know, I got it. I said, oh, they made a mistake. They're going to send me another one saying, sorry. So, you know, so we don't, I mean, you know, I don't know. You know, I think it's kind of like being bicultural. You know, you do have to learn to function in both worlds. And in a way, you know, yes, they're dualities, but in a way they're not, because they're both us, right? Who we are. You know, we're scientists, and we know the reality of our communities, you know. And you know, we can, I mean, I really firmly believe you can combine them. It may not be using all the traditional approaches and how somebody else may say how you should do it, but I mean, I do think you can do, you know, meaningful and impactful science that is relevant. But you're right. You have to really look at what is your starting point, and you know, is that going to get you there, and is it going to be sustainable? And you know, you may be able to prove in a very controlled study that this thing is perfect, and you know, you get high rates of whatever and changes in group by time interactions, but you go to take it to the community and it's not going to fit. So I started doing my research, you know, in collaboration with the city health department from the beginning. When I had the grants from the William T. Grant Foundation, those were based in young women going to the clinic, the prenatal care clinic there. And these other projects were also grounded there. And why did I do that? I knew that if I wrote grants from the university, there was going to be no sustainability. I was not going to start an intervention program that for 5 years and then it's done and over. We closed down. There's the storefront is gone. The services are gone. I was committed to not doing that. We've had a history of that happening in our community. So I said, I'm not going to put all these grants through the university. I'm going to put them through the city health department, and then they subcontract with me as the PI, you know, for a certain piece of the work. But we're going to create an infrastructure and build their capacity to have these services. And the staff will be their staff. You know, we hire in collaboration, you know. So I was very lucky to be able to find and hire and train a great clinician colleague. You know, without her, I couldn't have done it. Rita Nieves, and she's Puerto Rican. She's a nurse, has a master's in social work and an MPH. And she has a real estate license, too. She's one of those people that never stop. But, you know, and when we started, she had been, I hired her because I met her. I thought she was really good. She was the city TB control officer for the city health department. And in talking to her, she told me about how she started 13 TB clinics in Puerto Rico. And I said, I want you, you know, because that, you know, and nurses, my experience, happen to be very good at this. You know, she knew how to work within the system. She knew how to set up the infrastructure. She knew how to engage all the right partners. And she knew the patient population, because that's kind of the same population she'd been serving in the TB clinic. So, you know, I trained her on addiction, and we trained each other. And, you know, we had a lot of consultation because, you know, I was not trained to develop substance abuse treatment programs. You know, nobody in my, you know, cohort was trained for that. People did that who had lived experience. So this idea of having somebody who's a PhD do this was kind of not that usual at the time. So, but anyway, so I took it. I was concerned about accountability and continuity and not pulling the rug out from the community after you developed a program that was helpful. And, you know, I also did projects where the interventions were helpful, and I didn't continue those, you know. But so I think how you partner, and you got to have this in mind from the beginning. You know, what are you going to do about sustainability and the expectations you're creating? And the issue of duality, I think you have to kind of nurture both parts of that. You know, you have to nurture who you are, where you came from, your science part. You got to try to be as, you know, cutting edge as you can. And then it's also helpful to meet other people and to talk to other scientists who also are in the same situation. So one of the organizations that I helped to found about 15 years ago is the National Network of the National Hispanic Science Network. It happens to focus on drug abuse, but also on mental health and HIV, and we're expanding. So in that network, it's really, I get that a lot. You know, I get that interface of, okay, how do we apply science to the issues we want to work on? And we're able to have discussions. And, you know, these are people from who are doing work at the cellular or the molecular level to people who are doing public policy research. So we also said we're going to be very interdisciplinary and not just be behavioral scientists. So find those groups, you know, and find places and organizations that will nurture those parts of yourself, the intellectual parts, you know, of that intersect. Oh, you noticed I didn't answer that. You know, we didn't, so for the population I was working with in these studies in Boston, you know, there was, I think, no major, like, traditional medicine, like in a formal way, like real vast use of curanderos or sobadores, or, you know. But, of course, you know, that doesn't mean there weren't informal practices about what people tried to do, you know, to heal themselves. We didn't really do it in any formal way, so I can't say that was really addressed. I think that my approach was to really infuse our treatment and our intervention approaches and our staffing at all levels, including management, you know, from outreach to management, with enough people who had lived experience of recovery from addiction, trauma, and mental illness, and who had really good skills in specific areas. Some of them had degrees, some of them didn't. And to really have them really be real partners in the conversation and in forming our vision, and not just an advisory committee out here that, you know, you have because, okay, I'm required to have it, but so, you know, really believing that if you've lived through something, maybe, you know, you have something to share about what might be helpful. And seeing, I mean, you know, really realizing that they're an asset. You know, they're going to give you an insight that you don't get from a book. So I'm sorry, we didn't include that. Yes, other questions?
So at this time we can open it up, so definitely people with a bunch, go for it.
So in integrating across the systems for the treatment of women, did you integrate into early
childhood for their children? And how did you do that? How did you get the buy-in across those systems?
So I'll speak to that at two levels. One is the Women Co-occurring Disorders and Violence study had a sub-study that involved 4 sites. It didn't involve our site. That had an intervention that was for children. However, in our residential programs, we took kids into care, and we developed programmatic, also sort of treatment for the kids or interventions. So, there were assessments, there were early childhood folks who were integrated into our team, both in-house, and we had a wide referral network of partners that we developed. And so early childhood interventionists were really a critical part of that. A lot of times the kids came with many developmental delays, history of abuse themselves, behavioral problems. So major issue, you got a residential program with, 22 women, and each of them has 2 or 3 kids who have, not a lot of skills in anger control and parenting and all kinds of trauma. And so how do you manage that, because it can be chaos. So entre familia. Huh?
How long duration?
Oh, initially it was a year. Initially a year, and then we went down to 6 months, and now we're trying a 4-month approach, just because we see what's coming down the pike with healthcare reform, and long-term residential treatment, unfortunately, is probably not going to be viable. So, so as part of our residential treatment, we integrated that a lot of parenting, a lot of actual services for the kids. We actually have now a nurse visiting program, home visiting program. We've adapted that so the nursing team comes and does, instead of going to the home, when women are in residential, they come and do the assessment there, and then they follow them when they leave treatment to the home, and they keep following them. So they also work with, early childhood intervention specialists. We brought in a consultant who helped us to develop like a behavior management approach for the residential, where you get happy faces when you do X things. And that really actually is such a simple technique, that the parents learn, reduce the kind of problems we were having in the residential, by huge amounts. And it made the mothers feel more in control and like they were better parents. We do a lot of parent training, parenting training with the mothers. In the outpatient, we do referrals for things like that, but we don't do direct care of the kids. We do provide babysitting, because how can women go to treatment if you don't provide that? And we provide food, because if you don't provide that, they get hungry and they leave, and a lot of these women are homeless or have very limited sources of income and don't always have food security. So, okay, yes.
Hi, good afternoon. My name is Lisa Palucci. I'm a PhD nursing student and also a Robert Wood Johnson Policy Fellow at the College of Nursing here at UNM. And I just wanted to comment and maybe get your perspective. I love the fact that you use patient experience and talk about lived experience in your work. Mm-hmm. And you talked about how nowadays it is really more a technological aspect that a lot of our young people are experiencing now. Yeah. And I wanted to get your thoughts on, when you talked about inspiration, a lot of my not only lived experience of who has shaped who I am, but a lot of that came from the stories that my grandparents shared with me growing up. And this really speaks to how I have hopefully instilled that into my daughters that are coming into this age of technology, and so that they could live a very proactive and contributory life in this duality mode that we speak of when it comes to minorities in this kind of work, or just being people in society. Because I would hate to lose that if a lot of that is experienced at the technological aspect that you mentioned. So if I can just get your thoughts on that.
So my thoughts on what specifically?
On specifically how important it is to reflect on those stories that may have been shared with you growing up, and it's not your own personally lived experience, but maybe that you're living vicariously through those stories that were instilled in you growing up.
Oh, yeah.
Through ancestry and those sort of things.
Absolutely. And, in the, I think in our programs for women, we particularly have places where we create places for women to talk about the stories they heard. We focus it particularly on, stories or dichos or refranes about gender and, women that may reflect what they were taught about women, or what they maybe were taught about religion and God. Because in particular in this group of women, a lot of them, because of the shame, they felt like they could not even think about spirituality or connecting to God or to higher power, to something larger than themselves, that they didn't deserve it. And so that's really, a reflection of shame and feeling unworthy. So the spirituality curriculum is really not about religion. It's really about going back and look at what have been your spiritual traditions. What did you grow up with? What were the practices? And which of those, then trying to help them discern which of those are helpful or not. Because some are not. Some, invoked shame. Or, really are very limiting in terms of what women are expected to do or able to do. So, and then for them to redefine and reconnect with those helpful aspects going forward in their recovery. So, we did integrate stories, and refranes and dichos and things like that, which are really reflections of culture and socialization. So, because refranes and stories and all, they all carry a message, right? About what's right and what's wrong, or, what's good or what's bad. And in the end, most of them have some point to make. So they really teach us values and perspectives. So those are really very important. In fact, in the framework that I was telling you on cultural adaptation that Bernal wrote, the integration of cuentos and dichos and things like that is one of the dimensions that needs to be considered. Refranes, as, because those really are eliciting a deeper reflection of culture and values, and that's why. Yes?
I would like to give an example of that.
Oh, good.
For example, one of the refranes that I grew up with was el hombre dispone y la mujer, el hombre propone y la mujer dispone.
Sí.
That means man proposes and woman decides. And for women that are in body work, or for women that have been raped, there's a shame because they feel that they should have done something to stop what happened. So reflecting on that kind of refrain really can bring people, especially women, to figure out, where did that shame come from? And I remember very clearly, I was a social worker working with someone where that was the shame that came, that you have, or women that had gotten AIDS because of unsafe sex, and all those, and that's just one refrain. I'm sure you can think of 10 of them that shape how you develop what you think, and they are totally unconscious. Mm-hmm. You don't even know that those are the messages, but they are embodied. They are inscribed in our bodies and in our psyches, and they make it really difficult to get over them if we don't know.
Right, and those refranes and, cuentos have at the core, a message that isn't only related by that one refrain. That those messages are usually repeated in many forms through various aspects of culture and language, and traditions. So, their impact is pretty pervasive, yeah. Well, I think we've reached the end, unless somebody else wants to ask a question. Yes, please.
Gabe had to leave and be a professor, so he apologizes. I'm the person who has to thank Hortensia. I'm Frank Kessel, a senior fellow, member of the leadership team. Hortensia and I go back a long way. We both know one another when our hairs weren't gray. Our hair wasn't gray. But it's relevant in this way. This was when I was associated with the William T. Grant Foundation, and Hortensia received what was then known as a Faculty Scholars Award. It's a program that the foundation still has, in fact, not only for faculty, but now beyond the academy, which is interesting. And this was a program where young, promising scholars were given 5 years?
Yes.
5 years of
Fantastic.
funding for being released from teaching, doing things that, being freed from the things that make it so hard for people to establish careers, right?
Yeah.
And it's been a highly successful program, and what I'm here to say is that we placed bets on young people then.
You did? I
yeah.
bet you didn't bet on me.
Well, we did bet on you, and the point of the story, of course, is that we were right. Okay? That no faculty scholar could have been more productive and creative, not just academically and scientifically, but in terms of social and moral and deep contributions to the well-being of the society. So we're grateful for that.
Thank you.
For you being here.
Thank you. And since you brought it up, can I make a confession? Because this was really, it's years in my chest that I, and maybe you shouldn't tape this. But here's my confession. When I had this award, which was incredible, and it wasn't just, the actual financial support, but it was also the scholars that it exposed you to through the networking. Okay, so I got this. This was right in the middle of when the AIDS epidemic emerged, okay? And really before I began all this work on treatment in women and trauma. And as a young scholar, I never told you this. I never told anybody because I felt like so bad about it. But I really kind of had to face, a decision point. I mean, I had been funded to really do a lot of work on youth and adolescents, and I did that. But then I was starting all this other work that was really about the mothers of those children. And I felt that was really essential, that we could work with the kids all we wanted, but if we didn't work with the mothers, that, they weren't going to have a chance. But, I always, as a young person, I felt like really torn about sort of, in a way, what I felt was departing, from what I was supposed to be doing. But I was so compelled with the historical events of what were happening, that was, I was seeing in front of me, and then convinced myself that I was still working on children's issues because I was working with the mothers. So that's kind of how I resolved it in my mind, and I feel better now that I told somebody.